Welcome to Roadmap to Residency. Hello everyone, I am Aviraj. Welcome to our Top 250 Match Maker sessions. We are currently on our hematology sessions. We will be running through some questions with you guys to help you on your journey to a 250. So, which of the following is the most likely diagnosis for this patient's conditions? A pretty straightforward question asking us about the diagnosis. A 7-year-old child presents with complaints of fatigue, easy bruising, and frequent nosebleeds. Physical examination reveals pallor and petechiae. Lab tests show a markedly elevated white blood cell count with a predominance of lymphoblast. Bone marrow examination confirms the presence of lymphoblast, and flow cytometry analysis further reveals the lymphoblast to be of B cell origin. Now, which of the following is the most likely diagnosis in this patient? Acute myeloid leukemia, chronic lymphocytic leukemia, acute lymphoblastic leukemia, or Hodgkin's lymphoma, or multiple myeloma. So the most likely diagnosis for this patient's condition is acute lymphoblastic leukemia. So explanation is just based on the clinical presentation. The child presents with symptoms of fatigue, easy bruising, and frequent nosebleeds, which are common findings in leukemia due to the bone marrow suppression. The presence of pallor and petechiae is indicative of low red blood cell count and platelet count, which is often seen in acute leukemias. The lab test, the markedly elevated white blood cell count with the predominance of lymphoblasts suggests a rapidly progressive leukemia. The bone marrow examination showing the presence of lymphoblast in the bone marrow is a hallmark of acute leukemia. So the flow cytometry analysis, the identification of B cell origin lymphoblast using flow cytometry analysis points to acute lymphoblastic leukemia. So this is a picture of the acute lymphoblastic leukemia. Here you can see the large cell with round to oval nucleus with coarse clumped chromatin and inconspicuous nuclei and scanty cytoplasm. The main thing to recognize here is that the cytoplasm, you can see very little amount of cytoplasm in these cells, or you can see very less amount of cytoplasm in these lymphoblastic cells. So in examination, you will get pictures and you have to look for these cells in examinations, and that will save a lot of your time getting to the diagnosis or to answer the question. So let's talk about different types of lymph neoplasms. So this is the page from the first stage. We will just review these ones. So the acute lymphoblastic leukemia or lymphoma most frequently occurs in the children. Our patient was a 7-year-old child, and the less common in adults. T-cell ALL can present as mediastinal mass, presenting as superior vena cava-like syndrome, and is associated with Down syndrome. So sometimes question will just mention the features of Down syndrome, and that may be the only clue identifying the diagnosis in this patient. The peripheral blood and bone marrow have increased lymphoblast, and the TDT is positive, which is the marker for pre-T and pre-B cells. And the most responsive to therapy is the ALL, and may spread to the CNS and testis. So the mutation is the translocation of 1221 chromosome, or the translocation of 922 chromosome. So 922 chromosome is called as Philadelphia chromosome, and if there is defect in this sort of chromosome, then these patients have a worse prognosis. The chronic lymphocytic leukemia, the CLL, also called as the small lymphocytic lymphoma, is generally occurring in the age of more than 60 years. So the most common adult leukemia is the CLL, and it is CD20 positive, CD23 positive, CD5 positive B cell neoplasm. So often asymptomatic, progresses slowly, and smooth cells are seen in peripheral blood smear. The autoimmune hemolytic anemia may be also present in this patient. So you have to remember that CLL have crushed little lymphocytes or small cells. I will show you the picture. So the Richter transformation, where the CLL SSL transformation into an aggressive lymphoma, most commonly into diffuse large cell B lymphoma, large B cell lymphoma can occur. So talking about the hairy cell leukemia too, the adult males mature B cell tumor, and the cells have filamentous hair-like projections. So the normal cells that we have in our body, they are usually round, right? But if the cells will have hair-like or pin-like projection diverting outward from the cell, then that is called as a hairy cell, okay? And that leukemia is called as a hairy cell leukemia. But the peripheral lymphadenopathy is usually very, very uncommon in case of hairy cell leukemia. So that may be the only distinguishing factor between the hairy cell leukemia and other sorts of leukemia. So the peripheral lymphadenopathy is uncommon, and it can cause marrow fibrosis, where the thing is, when we do the dry tap, or when we do the aspiration of the marrow, then we can just see the dry tap. The patients usually present with massive splenomegaly and pancytopenia. So the trap stain largely is replaced with the flow cytometry and associated with BRAF mutations. The treatment is purine analogs like pentostatin. So let's talk about some of the myeloid neoplasms too. So the AML and the CML. So the AML is generally occurring in the median onset of age more than 65 years. The ORRs are present, and it is a myeloperoxidase positive cytoplasmic inclusions seen mostly in the APL. I'm just reading this just for you to recall the first day pattern. There is increased circulating myeloblast on peripheral smear, and the patient may present with leukostasis, which is the capillary occlusion by malignant non-distensible cells, leading to organ damage. The risk factors are the prior exposure to alkylating chemotherapy, radiation, benzene, and myeloproliferative disorders. The Down syndrome is typically acute megakaryocytic leukemia, formerly MSML-AML, responds to all trans-retinoic acid. And arsenic trioxide, which induce the differentiation of promyelocytes, and DIC is a common presentation in these sort of patients. The chronic myelogenous leukemia, the peak incidence is 45 to 85 years, and the median age is 64 years. It is defined by the Philadelphia chromosome, the BCR-ABL gene mutations, and myeloid stem cell proliferation. It presents with dysregulated production of mature and maturating granulocytes and splenomegaly. It may accelerate and transform to AML or ALL, and it responds to the BCR-ABL tyrosine kinase inhibitors. So let's talk about the AML. So the AML will show you a large cell with round to oval nucleus with fine chromatin and 2 to 4 nuclei and scanty cytoplasm with fine granules. And these cells are called the myeloblast. And in some cells, there may be crystalline cytoplasmic inclusions as a result of abnormal fusion of azurophilic granules. And these are the overrods. So these overrods are the diagnostic feature of AML. Now let's talk about one more question, and that is, what is the most likely diagnosis for this patient's condition? A 45-year-old woman presents with complaints of fatigue and early satiety. Physical examination reveals splenomegaly. Lab tests show leukocytosis with a predominance of mature neutrophils and increased basophils and elevated platelet counts. A bone marrow biopsy reveals hypercellularity with an increased number of granulocytes, including mature neutrophils and increased megakaryocytes. Cytogenetic analysis demonstrates the presence of Philadelphia chromosome T922. What is the most likely diagnosis for this patient's condition? CLL, ALL, essential thrombocythemia, CML, or polycythemia vera? So the most likely diagnosis in this patient is CML, or chronic myeloid leukemia. So the patient presents with fatigue and splenomegaly, which are common findings in CML due to the overproduction of myeloid cells. The laboratory findings include leukocytosis with the predominance of mature neutrophils, increased basophils, and elevated platelet counts, which are typical in CML. The bone marrow biopsy reveals hypercellularity with an increased number of granulocytes, including mature neutrophils and increased megakaryocytes. This is a characteristic feature of CML. The presence of Philadelphia chromosome is a hallmark of CML, and this chromosomal translocation leads to the formation of BCR-ABL fusion gene, which plays a central role in pathogenesis of CML. So here you can see again the histology of CML, the peripheral smear showing immature granulocytes, basophilia, and eosinophilia. So this one is the promyelocyte. This one is the metamyelocyte. This one here you can see is the basophil, neutrophil, eosinophil, and these are the band forms. So varying features, varying sort of cells are present in case of CML. You just need to remember that, and you will be able to catch the diagnosis in your examination. Also, you can see the CLL, where you can see the small lymphocytes, and these are the small cells. And these small cells are the diagnostic feature of the CLL. Now, let's talk about one more question. So, what is the most likely diagnosis for this patient's condition? Again, so a 28-year-old woman presents with paleness, enlargement of cervical lymph nodes, low-grade fever, and night sweat for the past few weeks. Physical examination reveals firm, rubbery, and discrete lymphadenopathy in the cervical region. A lymph node biopsy is performed, and histological examination reveals Reed Sternberg cells surrounded by a mixed inflammatory background with lymphocytes, eosinophils, and plasma cells. What is the most likely diagnosis for this patient's condition? Non-Hodgkin's lymphoma, ALL, Hodgkin's lymphoma, CML, or multiple myeloma? So the most likely diagnosis for this patient's condition is Hodgkin's lymphoma. Clinical presentation include the patient presents with painless enlargement of cervical lymph nodes, low-grade fever, and night sweats. This is characteristic of Hodgkin's lymphoma and is often referred to as B symptoms. The presence of firm, rubbery, and discrete lymphadenopathy in the cervical region is typical for Hodgkin's lymphoma. Histological examination reveals red stomach cells surrounded by a mixed inflammatory background is a classic finding of Hodgkin's lymphoma. The red stomach cells are large binucleated cells that are characteristic of this disease. Now let's differentiate into Hodgkin's and non-Hodgkin's lymphoma before we finish this class. So Hodgkin's both may have constitutional B symptoms, that is low-grade fever, night sweats, and weight loss. But in Hodgkin's, there is localized single group of nodes with contiguous spread. That is the state's strongest predictor of prognosis and generally have a better prognosis. But in case of non-Hodgkin's lymphoma, there is multiple lymph nodes involved. The extranodal involvement is very, very common, and there is non-contiguous spread, and these patients generally have a worse prognosis. It is the Hodgkin's is characterized by the red Sternberg cells, and the non-Hodgkin's is characterized by majority involving the B cells, rarely of the T cells lineage. The bimodal distribution is present in case of Hodgkin's lymphoma. The young adults may be involved, or the patients more than 55 years of age may be affected in this disease. The non-Hodgkin's lymphoma, they can occur in children and adults. So associated with Epstein-Barr virus is the Hodgkin's lymphoma, very, very important concept, and may be associated with some autoimmune diseases and viral infections like HIV, EBV, and human T leukocyte virus. Okay. Now, one more question before we finish. So what is the most likely diagnosis for this patient's condition? A 60-year-old man presents with generalized weakness, night sweats, and unintentional weight loss of 10 pounds over the past few months. Physical examination reveals painless generalized lymphadenopathy. Lab tests show anemia and an elevated lactate dehydrogenase level. A lymph node biopsy is performed, and histological examination reveals a diffuse infiltration of a small lymphocyte with no red Sternberg cells. What is the most likely diagnosis for this patient's condition? Hodgkin's lymphoma, ALL, non-Hodgkin's lymphoma, CML. Now, the most likely diagnosis for this patient's condition is non-Hodgkin's lymphoma. The clinical presentation, the patient presents with generalized weakness, night sweats, unintentive weight loss, and painless generalized lymphadenopathy. These are indicative of lymphoma, but the absence of red Sternberg cells suggests non-Hodgkin's lymphoma. The presence of anemia and an elevated LDS level is consistent with lymphoma. LDS is often elevated in cases of lymphoma, reflecting the increased cell turnover. The histological examination reveals diffuse infiltrates of a small lymphocytes, which is characteristic of non-Hodgkin's lymphoma and which lacks the red Sternberg cells seen in Hodgkin's lymphoma. Thank you for watching. Keep studying hard.